Really, we're looking to see if this case really needs to be restored, if it needs ortho.
A patient in his 60s, look at his mouth. It looks like a 4-year-old's mouth. It's so small. Overjet is almost like 6-7 millimeters. It's huge.
It's been a tiny miracle to watch the difference in patients when you get that posterior uprighting and then you get your transverse as well as but that's the whole point about pitch, yaw, and roll is there's a lot of factors going into getting a full solution for the patient. But this is probably the best starting point that we're going to have, is to have a known position. This is where we need the mandible to be. Now get the teeth there, whether it's ortho, restorative, or both. Now you've got an opportunity to deliver, really like a best-in-class treatment for patients.
Welcome, everyone. I am so excited to be here. I am Lauren Gates, host of this evening's Airway Health Solutions Masterclass, and the topic is, what's all the buzz about Myoaligner? And I am thrilled to feature the dynamic, innovative, and delightful Dr. Maryam Motlagh. Welcome as our featured guest. And we have our panelists. Everyone knows Dr. Miraglia is the Chief Clinical Officer of Airway Health Solutions, and Dr. Michael Gelb, world-renowned TMD specialist and also distinguished faculty of AHS. So welcome, everyone. Welcome, everyone who is with us. We're excited to be here. And this is basically like the dream team right here. I'm just looking at the three of you and the power you have to help your patients breathe, sleep, and thrive. And I'm thrilled to have you all here to share your expertise and helping everyone learn also how they can in turn help their patients by learning from all of you. So on behalf of myself and all our panelists, I want to extend a warm welcome to everyone. We have about 600 tonight, so I'm thrilled, which is a testament to our airway health movement moving forward. So as long as you guys show up, we will continue to show up. And let's go ahead and see a poll of who's with us tonight. I always love to see what we have going on, and if I can go ahead and start that. Okay, yeah, please choose the best description that fits you, and I am sorry if we don't have enough to go around with the descriptions, but maybe you can put it in the Q&A, your profession, if it's not listed. So let's take a look. We have about 70% participation. Okay, so we have a nice mix here. Heavy on the dentist, so dental hygienists and pediatric dentists and orthodontist, a prosthodontist, and okay. So welcome, everyone, and again, congratulations for your participation, because we're thrilled to have you. Without you guys being here, we wouldn't be here, so we can all move the needle forward. Just a couple of housekeeping items, and then we'll have a nice discussion before we start. We are ready to kick off tonight with a special raffle. We're going to offer our free tuition to the Fundamentals of Airway course, so stay tuned until the very end. And also we are happy to offer 1.5 CE units tonight, so credits. So in order to receive your CE certificate, you must be in attendance for the entire program. The Zoom software does track your attendance, so we do not need a code, you don't need a survey. And then just a few disclaimers, and we will get rocking and rolling here. The views presented are the opinions of our speaker and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions. And the following webinar is provided for educational, informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Okay, so let's talk shop here a little bit. So here we are, all around as panelists. I'm going to ask Dr. Miraglia and Dr. Gelb to come off mute for a moment. And when I first put together this masterclass, I really thought of you two being on as panelists. And maybe Dr. Motlagh, Dr. Gelb, Dr. Miraglia, you can describe how you all became together. And I know, Dr. Miraglia, you mentioned that you talked about this with Dr. Motlagh last November. So let's kind of like level set here. Dr. Motlagh, I'll kick it off with you on your goals for this evening and why we have Dr. Miraglia and Dr. Gelb with us to support you.
Hi, everyone. It's a pleasure to be here with you all. I think we're all in the bite and airway circle. That's how I met Ben, and started. I've been a restorative dentist, airway and TMJ, from a physiologic approach. And our philosophies just align. And I sat through some of his lectures, and I've known Michael Gelb in this field for a long time. So it's very nice to be able to collaborate. There's so much need out there, and I'm glad that we have dentists that are now interested in expanding their services.
Thank you. And
You want to
ahead,
go
Ben, you
first,
wanna-
Ben?
Yeah, sure. Yep. So I met Dr. Motlagh a long time ago, and I've seen her lecture, I've seen her work, I've seen everything she's doing. And over time, of course, having done everything right, she's got her FDA clearances now and approvals, which is beautiful. So the work is fabulous. I'm so glad to have it as part of our, education as well as part of the toolbox, because the more you have, the more you can help your patients. There's a lot of different opportunities out there. I'm very excited for our AHS family to see this and have this opportunity for their patients. I think you're going to be amazed when you see everything that she's done and put into this and where it is and how incredible the opportunity is. So I'm just as excited to be here and watch this, even though I've seen her lecture before. It's just wonderful, wonderful collaboration. Really happy to be here.
Yeah, and I can echo that. I mean, we've worked together. I'm also a customer of Myoaligner, and we use it either as a transitional step, before we'll get rid of the symptoms, bringing the jaw into a very similar position, and then we'll work with the Myoaligner device pre-ortho or pre-restorative as a transitional step, which the patient can use very nicely for speaking clearly and eating and functioning with the support that we want to see them have, and the airway opening.
We'll
Great.
be sharing several
Thank
of
you.
your cases. Thank you.
Well, I'm excited to learn as well from you, Dr. Motlagh, because I've heard so many wonderful things and I haven't seen the cases yet. So I'm excited for this presentation for personal reasons. But let's go on, kick off. I'm going to have you share your screen, and I'm going to give you a formal introduction as you do so. So Dr. Maryam Motlagh is a general and cosmetic dentist based in Portland, Oregon, with a distinguished focus on TMJ, TMD, airway health, and holistic functional dentistry. She graduated with honors from Oregon Health and Science University School of Dentistry and pursued extensive postdoctoral training at prestigious institutions, including the Academic of Cosmetic Dentistry, Spear Institute, Las Vegas Institute for Advanced Dental Studies, and the Epigenetic Orthodontic Program under Dave Singh. As a fellow of the International College of Craniomandibular Orthopedics, Dr. Motlagh developed a patented Myoaligner and FDA-cleared, congratulations, non-surgical appliance treating TMJ disorders, migraines, and jaw misalignment. Does anyone know patients with that? Her work emphasizes a multidisciplinary, non-invasive, and bioremodeling approach to treating occlusion-related disorders. She leads an active practice in Portland and engages in speaking and education efforts and aims to empower general dentists through innovation and hands-on training via the Myoaligner Academy. So welcome, and I'm actually thrilled to welcome that you are a future faculty member of the AHS come 2026. So that's the first time I'll introduce you as that. So welcome and take it away, Dr. Motlagh.
Thank you. I'm looking forward to our collaboration. I want to start my slides with problems. Why does it matter? Why are we here in the evening after a long day of work, all of us trying to learn and expand our knowledge? And the main reason is that we know that millions of patients are suffering. Actually, a recent study that was a mega study on the prevalence of sleep apnea and TMJ disorders showed that 30% of adults and 11% of children are suffering from TMD. Imagine 30% in a small practice of like 2,000 active patients. That's 600 adult patients that are suffering, and a lot of them don't know that we can help them. And unfortunately, that's because a lot of these patients go untreated for many years. And the existing treatment options, they think that is very invasive, non-affordable, non-accessible. So our goal, our mission at MyoHealth Technologies is to make treatment more accessible to more patients. 30% of patients in the US alone, that's 100 million patients. We only have 170,000 general dental practices in the US. So just look at that ratio. 100 million patients are suffering from from pain and discomfort, and they're medicating, with over-the-counters, with prescription drugs, and not getting to the root of the problem. So what we're trying to do is to empower general dentists with simple solutions to complex problems. We see our patients more often than their MDs, so we're at the forefront of helping these patients. We see them every 6 months for their cleaning. This is dentists are in the best position to help TMD and airway patients. In a nutshell, there's a big correlation between malocclusion and airway. In modern societies, we don't know how to breathe properly. There's pollens, there's allergies, there's all the industrial revolution and the food that we have allergies to. So a lot of us are breathing through our mouth, and we have hypertrophic tonsils and adenoids, and that really changes our breathing from a nasal cavity to our oral cavity. And as soon as that happens, the palate starts to collapse. You can actually watch a 2-minute video on these slides that I have. It's on YouTube. It's called Airway and TMJ. That link is included in every email that I send to my patients, because in 2 minutes, they understand the relationship between their occlusion and the airway. So when the tongue muscle is not in the roof of the mouth with every swallow to help form that midface properly, the palate collapses and it appears as malocclusion. 86% of the population has malocclusion. So you can imagine that, the number of patients suffering is probably more than that 30% that study came up with, because a lot of people don't know that their pain is related to this. So palate collapses, teeth don't have the room to come in the right position, and they start to get crowded. And mandible just follows the maxilla. We call the maxilla the criminal and the mandible the victim, because the mandible is no longer fitting in that maxilla properly. And because it's just hanging from the muscles, it can adapt by retracting or tipping to the side, and it can trap the airway, and the patients will have a forward head posture to open their airway, and they will swallow incorrectly, and they just adapt. But the main thing to remember here is that the mandible is moving like a plane. It doesn't move like a car. It has pitch yaw roll movements. So when the position of the mandible changes, one joint can be affected, one side of the body, and it can go all the way down to the hips. So I really want to change the term VDO to PYR, pitch yaw roll of the mandible. And so when we are starting to treat these patients, we just have to arrive at that physiologic rest position that we all learn at dental school. That's the best position to start a denture or full mouth reconstruction. So there's different philosophies out there. We can arrive at that ideal mandibular posture in different ways. I use a TENS machine. That's how I was trained. I know some people look at the joint position with CT scan. I know the Gelb Center uses more of a phonetic bite techniques. So if you guys want to chime in and maybe share the way that you arrived at that mandibular position, would be a good time right now. So it doesn't really matter how we arrive at that position, but that would be our treatment position or our constructive bite position.
Yeah, I mean, I think you have to take a lot of factors into account: the patient's symptoms, the exam, TMJ exam, airway exam, tongue, myofunctional, aesthetic, and everything. You have to align all these data sets to come to your final 3-dimensional roll, yaw, and pitch position that's going to allow the patient to get better, to heal. And we're all looking for that position. I'd say it's most likely not going to be back. It's going to be up against the eminence, and it's going to be in an open airway position.
Exactly.
And ideally in a position where there's no clicking and popping. And like Ben Miraglia says, it's a position where the symptoms can be alleviated prior to commencing ortho, prior to commencing restorative. And it's really, we're looking to see if this case really needs to be restored, if it needs ortho. We're looking, like Ben does, we're measuring the molar to molar distance, we're measuring the canine to canine distance, and we're really evaluating everything, but really getting the case set up.
Yeah, so I would say ditto. I mean, I learned from Michael. So yeah, same thing. It is developing that upper jaw to free the lower. And if you can find your position first, then you know exactly where you're treating to. My early days were the baby steps of just keep incrementally growing the upper jaw till the lower jaw found a spot where, hey, the patient has no more symptoms. So I was taking the baby step to get there. This system delivers that position immediately. And then you know at the beginning, at the start, this is where I need to finish with my ortho and my restorative to have my patient be totally asymptomatic and pain-free means medication-free, breathing better, sleeping better, the whole thing. So yeah, I absolutely love this. Basically, you have developed and proven a way to set everything up from the start with exactly where you need to be at the end, whereas all I was ever doing was taking an incremental step until I knew my patient had like the credentials of happy, healthy, comfortable, pain-free, medication-free, sleeping, breathing better. But I was just doing a baby step at a time, wider and forward until I got there. I never really knew at the beginning where I needed to finish. I just knew they were trapped and had to go forward. And so there I was, educated guessing, but this is so much nicer, so much nicer.
We all learn physiologic position, physiologic rest position, you know, at dental school, where the muscles where the masticatory muscles were happy and the mandible landed in the right position, and obviously, you know, the joint will follow too. So, but it's the teeth. At the end of the day, it's the anatomy that really maintains the balance and homeostasis, maintains the muscles in a happy, restful position, maintains the joint in the center of the fossa. And it's a neurofeedback through the periodontal ligament and through the trigeminal nerve to our nervous system. You know, you've all placed crowns and fillings that were just slightly high. 40 microns is our how much we can have an error in the mouth. You know, and patients will feel that. How can we feel 40 microns in our teeth? And that's because of the direct connection to the trigeminal nerve and the central nervous system. So that's why we have to really take occlusion seriously. And that's why, you know, the concept of anatomical orthotics was built several years ago, you know, decades ago. And the definition of orthosis is basically the science of aligning body parts to improve function, based on, you know, Bob Jenkinson, who was one of my mentors. So this is just one example. One of my patients, he had a bicuspid drop off. You can see that in the posteriors, starting on the bicuspid, we have restored him with a Myoaligner. When I remove the Myoaligner, this patient will collapse into a really deep bite, pressure on the joints, difficulty with airway day and night. So the orthotic is just a really safe way for you to test drive your construction bite, basically, before you go to phase 2, which is non-reversible. Phase 2 restorative or orthodontics is non-reversible. But an orthotic, especially when used during the 3 months prior to those big cases, is a very good, safe, non-invasive way to approach this. So this is a video of a patient in his 60s. Look at his mouth. It looks like a 4-year-old's mouth. So small, you know, and that overjet is almost like 6-7 millimeters. It's huge. So every time that he swallows, his problem is not just at night. Every time he swallows and he meshes his teeth together, there's just his airway is closed up. And when we bring the jaw, when we jumpstart that mandible forward and let the joints heal, let the body heal in that position, that's why we call it more of a bioremodeling device, because patients can wear these day and night and get used to that position. It's almost like a cast for a broken leg. You know, if you have a broken leg and you want the joints and muscles to heal and the bones to heal, you cannot just wear it at night. During the day, people need to be able to swallow and function correctly. So that's why we developed Myoaligner. It's to restore the anatomy, to restore function and aesthetics 24/7. I never forget that a few years ago at Collaboration Cure, during the breaks, I was taking like myobites on patients or on volunteers. Most of them were dentists. And I talked to this dentist that was probably in her late 40s. She had the tiniest nostrils. So I asked her if she ever breathes through her nose. She said, no, I've never breathed through my nose. So I brought her jaw forward and I just stabilized it with a bite registration. She ran to class. She came back about an hour later. She was in tears. She said, for the first time in my life, I was able to breathe in just that 1 hour that she was in class. So that shows you that just by just moving the mandible forward, her posture improved, her airway opened, and this whole system is connected. She was able to breathe through her nose. As soon as we establish nasal breathing, nitric oxide gas is going to be released, and it's a vasodilator. So she just felt so much better. I think she was just in that parasympathetic mode for the first time, just crying and showing me that that she felt the results in just 1 hour during the day. Imagine if that patient is in that position for years, she's going to feel so much better. She's going to sleep better and feel much healthier. So that's why we developed Myoaligner to be a 24/7 solution, basically to jumpstart the bioremodeling, the muscle reprogramming, and allow the joint to, so if patients can chew and function with it, they can use a little bit of a polygrip powder and cement it on, or the dentist can cement it on with a temporary cement and to jumpstart the healing and bioremodeling. And there is research behind why it's segmented. And I can share the research with you in the next few slides. The mandible flexes. So if you're functioning with a full arch device, it can cause temporalis tendonitis. It can put pressure on the mandible. Actually, craniosacral chiropractors and osteopathic physicians, they really like Myoaligner because they don't like splinting the right and the left side of the body. And just for the same reason that we don't place a bridge from 18 to 31 as dentists, we know that fractures, if you function with a full arch device, it can put pressure on the device, break your device, and also cause some pressure on the mandible and joints. So we resolve that problem by segmenting the Myoaligner. It usually covers the 2 posterior segments, or if anterior guidance is needed, it has an anterior segment too. Also, the segmentation allows the technicians to make the occlusal table much smaller. So we're not taking as much tongue space, because if the teeth are lingually inclined on both sides and you kind of like wanted to draw a big device that just have one line of draw, you have to cover a lot of undercuts, and that makes the occlusal table really big. So these will be a lot more delicate, and in the mouth, it's just the game of microns. If an appliance is smaller by just a few microns or millimeters, it's much more comfortable for the patient. So we are avoiding mandibular flexure, and we are increasing tongue space with this design. So our file was at the FDA for many years. They looked at it, and they approved it as a treatment for migraine headaches and TMJ disorders. They treated this like a class 2 medical device. So we've been able to get medical insurance coverage on it, which is great for our patients. Again, our mission is to make treatment more accessible to patients. So if we can get medical to cover it, that's great. I'm going to go into some of the applications of Myoaligner so you can see how we're using it. For example, before aligner therapy, a patient this is a patient from the Gelb Center that was recently submitted to us. You can see as this patient bites down, probably 100% deep bite, TMJ disorders, bruxism, narrowing of the maxilla. Michael, this is your patient if you want to chime in a little bit. So we built a Myoaligner to that. You delivered it a few months ago, I think. And in this angle, you can see the angulation of the Myoaligner that was built on that. So you can see the angulation of those teeth that are taking tongue space. Imagine by just uprighting those molars, up at both on the top and bottom, this patient's going to get so much more tongue space. But again, back to the pitch yaw roll of the mandible. Before you start, how do you know this is going to be your treatment position? It's a lot of guesswork, as Ben mentioned. If we just, yes, clear aligners can kind of like act as a night guard or a deprogrammer and allow the mandible to kind of like fall in the right position. But that's many appointments of refinement. That's why we know when you finish a case and you see how you have a posterior open bite, and that's very hard to close. So right off the bat, we start in that position, test drive that position for the patient, make sure they can chew and function, make sure they're pain-free, joints are in the right position before we go to phase 2. Michael, did you want to talk about this case a little bit more?
Let me chime in, because I'm chomping at the bit looking at some of these cases, and I think I know Ben is also. So, we do an appliance maybe for 6 weeks, 8 weeks, 12 weeks. The symptoms are a lot better, but perhaps they're still having pain on chewing. Or we want to, thinking of going ahead, but like Maryam said, that we want to take it on a test run. We want to take the Ferrari out or the Porsche out and see how it functions with chewing. The patient's going to do much better with the myoaligners than they would do with my appliances, because they're thinner, they can speak clear. But the point I want to make is that following this, what Ben's shown us is that we've got to expand that maxilla. As good as Maryam and I can get the patient, and we can get them really good, they're never going to be as good as they are after Ben finishes them. Once Ben makes room in the maxilla and makes room for that tongue, and then he can upright the lower teeth, they're going to feel twice as good almost as we're going to get them feeling very, very good. But Ben's going to make that room that you can really only do orthodontically. Some cases need, jaw surgery, but most cases don't. And, Ben will definitely opine on that later. But, from us working together, as good as I could get the cases, he could take them to the next level, like with doing something like this.
Yeah, it's exactly right. Everything that you guys do to set this up, it makes me look good. I get in there because I got a comfortable patient to work on. And then all of a sudden, I already know this is where the endpoint goes. And sure enough, I'm going to go for that posterior uprighting because, giving the position of the mandible, having the open now set. I do love what Maryam was saying about changing VDO to pitch, yaw, and roll. That is so much nicer to have that than just VDO, because vertical is just one. It gives the linear approach of just a straight line opening more. But meanwhile, the mandible's kind of free floating and has all these different components to it. So I think that's an incredible upgrade to go from VDO to pitch, yaw, roll. And then the posterior uprighting, yeah, it's been a tiny miracle to watch the difference in patients when you get that posterior uprighting, and then you get your transverse as well as but that's the whole point about pitch, yaw, and roll, is there's a lot of factors going into getting a full solution for the patient. But this is probably the best starting point that we're going to have, is to have a known position. This is where we need the mandible to be. Now get the teeth there, whether it's ortho, restorative, or both. Now you've got an opportunity to deliver, really like a best-in-class treatment for patients.
Yeah, and I think going back to what Maryam said in her introduction, when Ben talks about the work of Corricini or Rose, and the guys he's visited, the guys that we know that the skull today is not the skull of what we had 300, 400 years ago. So most people, their maxillas are retracted. Read Lieberman's book from Harvard. We don't have a snout, and most of our upper jaws are retracted. So most people, I would say a lot of people, need this type of treatment. And there's a school of thought out there that only use flat plane appliances, never change the bite. And I think anyone that has that thinking is thinking like from the 1920s and 1950s. We're talking about, thinking like it's 2050 right now.
And
Dr.
you're
Motlagh,
absolutely right. Yes, go ahead.
I was just going to just interject with a couple of questions that maybe we can clarify during the presentation here, rather than wait to the end. Is one, does segmentation, does it not create the risk of swallowing one of the pieces? Maybe you could just address that quickly.
Actually, no. That was one of my main concerns back in 2017, but we have done thousands of these, and we haven't had any cases that has come up, with swallowing, and they're bigger than a single crown, on number 31 in a Bruxer that we do. So, and patients, and that's why part of our onboarding is to use patient care instructions that was again approved by the FDA, to make sure patients are using it properly. We use some kind of adhesive for them to put it on. And as long as patients follow the protocols, we haven't had any issues. That's a great question. Thank you.
Thank you. I just want to clarify.
And so if you'd like to learn more of the technique, I'm sure Dr. Miraglia's courses cover this. You probably saw some occlusal attachments. So, when you mentioned flat occlusal appliances, some dentists use the flat appliance. They get the TMD to calm down because they're basically eliminating a pathological occlusion. But when they go to ortho, they start with that pathological occlusion. So their mandible can be canted, and that's where they're starting. And as you see in this case, if the patient bites down, they're going to retract, but we held them in that Myoaligner position where they were comfortable, and then we're tripoding and holding with those attachments that you see. We're holding that position until we can upright the teeth. So these aligners kind of like have the orthotic built in, and you need to take your photos in that position so the aligner technicians don't just take you back to the pathological occlusion. And hopefully that will be more practiced by everyone, but you have to be really specific with how this posterior open bite is actually your treatment or your construction bite, your final bite.
One more question to address before moving forward. Dr. Haller says, so they go from being comfortable in the Myoaligner back to their old bite and clear aligners. Could you clarify that?
No, they actually, this is their Myoaligner bite. So we continue their orthodontic positioning in the Myoaligner bite. So we correct the bone position, orthopedic position of the mandible, and that's where we start. So if this patient bites down, they're going to retract. You're going to see over 50% deep bite and a class 2 bite. So we brought them into the class 1. We make sure that the patient is comfortable there, and then we move the teeth to that position. And the reason for those posterior attachments were to tripod and hold the mandible in that comfortable position.
So let me clarify, because it's not totally clear to me. This is for Ben and Maryam. I'm going to be the Lauren, I'll help out a little bit. So the question from the audience is, how do you hold the bite once you get to this great bite that I'm talking about and you're talking about and Ben's talking about? I'll ask 2 or 3 questions. Do you do the upper arch with clear aligners and align it like Ben does and keep the lower there? And if not, if you're going to then get rid of the Myoaligner, and go to clear aligners, how do you hold it? Do you do turbos on the top end? Are you giving them posterior support? Or do you think that they can survive for the 6 weeks that it takes to get those upper anteriors out of the way? I'd like to hear from both of you. If you're both doing clear aligners, I'd like to get your philosophy on that. I'm interested in how both of you do it.
Yes, the purple turbos that you see on this case, that's exactly what it does. It holds the bite in that position because this patient's front teeth are almost
the purple.
tattoos.
What are those purple? What is the purple?
The purple is the turbos that
They're
go on the
from the back
aligners.
teeth.
Yes, they're like lifts on the aligners. They're not attached to the back teeth.
Oh, they're lifts on the aligners. That's what I'm saying. So you do provide posterior support.
Yes.
And is that customized?
Because Myoaligner is segmented, we remove once we arrive at that comfortable position, we remove one segment and we scan the bite right there. And then we remove the other segment.
Can the clear aligner folks, can they make those turbos, given the yaw and the roll, given the 3-dimensional changes that you've had, can the aligner people make those turbos to the exact height of where you had the Myoaligners? Or are they just doing stock millimeter, 2 millimeter, 3 millimeters?
They can do it as long as they're not super tall. And that's because the aligners are still press form that we use, pressed aligners. In the future, when we have 3D technology aligners, we can make them as tall as we want. So the answer is yes.
So you're saying
yes, there's some limitations right now. Yes.
You're saying ideally it is customized to the thickness of the
customized. It's basically similar to the attachments, but instead of putting it on the side, they put it on the occlusal, and they can do top and bottom. So I have pretty severe cases that I've done the turbos both on top and bottom until I upright everything.
And Ben, I know you're a little bit of a cowboy sometimes, but I'm saying that in a positive way. How do you do it? When you take a case like in my position and you go to clear aligners, Do you just go?
In the past, I would just go because in the past, from the day one, the treatment plan is showing back teeth wider, front teeth forward. So I know the top teeth are getting out of the way from the very first aligner. And I know the aligner thickness gave me at least the starting point of having the couple of millimeters of separation. But this is the future right here, is getting those, what Miriam's referring to as turbos, but it basically is like the attachment form. And when you have a 2 millimeter range, you can do 2 on bottom, 2 on top. So you really have a 4, almost 5 millimeter range that you can accommodate for the patient who is very collapsed. So don't be afraid of a 5 millimeter gap, because with them on top and bottom, now you've got your tripod resting, then you don't have to worry about it. So in the past, what would happen is our mild to moderate patients would switch from your pathway of comfort into the aligners. They might have a tiny setback in the first few months, but then we're back to the races. In other words, it's almost like I might have a 5-step backwards to then go 20 steps forwards.
No, I know.
In the removal. This takes that away from me now. And then the moderate to severe patient is really going to appreciate this, because moderate to severe, when I switched them to aligners, there's a little bit of a curve where, okay, those first few weeks or first couple of months, I don't feel as good as I did with these, but it's coming, hang in there, and we get there. But this is comfort from the start, because you're transitioning from comfort to comfort, maintaining that same position. And like Maryam said, the future is being able to make those fully customizable to exactly what you want. Right now, though, you do have a range of about 5 millimeters you can absorb, which is that is technically customizable fully, because 5 is a lot. I think it's an outlier for someone who would be 6 or more open, you know?
Yeah, I love it. I've never seen this exact approach, and I think it's fantastic.
Yes, we're doing several cases as a pilot study, so I can share more in the future courses. It's really exciting. And then in the future, when we have 3D technology, more mainstream and clear aligners, we can attach buttons and kind of like turn them into a mat device at night. It will be really nice. But right now we have some limitations with the current aligners. Great. So applications after aligner therapy. Now, a lot of these patients have had worn down dentition. You know, you can align the teeth, but they're just not the right height and dimensions. For example, this patient, she was a 4 bicuspid extraction, severe sleep apnea. You can see with expansion orthodontics, and I believe this patient was started with a DNA device, a palatal expansion. So we gained room for where the bicuspids were extracted. She had orthodontics done, so everything is aligned, but everything is just super short. Her video still collapsed. And so with this, again, we are correcting the pitch yaw roll. This is kind of like our mock-up before full mouth reconstruction. This looks beautiful, and it helps us to stabilize the bite, to manage the bite, customize the process, make sure the patient likes the aesthetics, make sure they can function with it. There's nothing worse than doing a full mouth reconstruction and then the patient coming back and saying, I'm happy. Nobody wants to remove 28 bonded restorations, especially the zirconia ones that we're making. So this really helps us before we prep a single tooth. You know, before we used to do diagnostic wax up, but we had to prep the teeth. And now we don't prep the teeth. We can still make these very delicate because there are 3 segments. So we can have different line of draws on each side of the arch and test the cosmetics, make sure the patient's happy before we go to the next phase. And then one of the most challenging things in full mouth reconstruction is managing the bite. Let's say you have the upper and lower, you finally arrived at that ideal relationship of the craniomandibular position or craniomandibular sacral position. You have that, but when you prep 28 teeth, it's very easy to lose that. With this, any general dentist can just use one segment and treat it like a quadrant dentistry, have the other segments in and bring the patient in throughout several appointments and just do one side of the arch or one quadrant at a time. So it makes it very predictable. It makes it affordable for patients. And it's just really easy on the body not to have to prep 28 teeth in one appointment. We're happy to answer any questions, as we go. So Another case, that we had from the Gelb Center that I want to share. This gentleman was actually started treatment with Dr. Gelb and then finished with Dr. Montrose at the Gelb Center. So he came in, he was going to the pain clinic in New York, had a lot of severe pain, was on multiple medications, had an anxiety, poor sleep, problem with focus, difficulty chewing, and a lot of facial asymmetry. You can see the lower jaw, just look at the retraction of the lower jaw. You can see the asymmetry on his lips and, eyebrows. You can just see all of that. Unfortunately, we have his eyes covered, but you can kind of like see that his eyes are at a different angle because the sphenoid bone moves, with the mandible and with the hip. So before and after Myoaligner treatment, his facial symmetry got much better. You look at his lip on this, right? Look at the corner of the lip right here. It's more leveled. His smile changed. His lower jaw looks much better. His neck posture looks much better because he's not adapting. So this is what they did for him in his mouth. Now, this patient came from Middle East. He came for treatment. He came for pain management, but he ended up at the Gelb Center, and this is the type of treatment that he received. So he was missing some teeth. You can see the deep bite right here. You can see how his tongue, even when he has his mouth almost open, his tongue is really struggling for space there. So you can see that they opened, they arrived at that physiologic position, and they secured him with 3 segments on the bottom and 2 segments on top. His front teeth are still his own teeth, and that resolved all of his symptoms. So this is the type of work that you want to do. I mean, this patient can now go into ortho to improve the alignment of the front teeth a little bit. He's had a lot of wear, or he can just be a full mouth reconstruction case to finish this case really quickly. Ortho would be ideal, but at least you can test drive it. All his symptoms were resolved, and it's a very good non-invasive way for a patient to test drive a new occlusion before they really commit to long-term treatment. This is another case. Patient came in with severe headaches on the left temporalis area, radiating pain on the lower jaw, acid reflux, snoring, excessive sleepiness during the day, and poor posture and neck pain. You can just see, look at the forward neck posture. This patient's trying to keep their airway open. I've seen a lot of patients going to physical therapy for years for their neck pain, and as soon as their jaw is in the right alignment, their neck posture improves. So with every swallow, which happens 4,000 or 5,000 times a day, these patients are compensating. They're closing their airway. We need to breathe during the day and night. So this type of treatment is not just for snoring. And if you look at her occlusion, if she ends up at the most general dental offices, she's class 1 occlusion. She has a little bit of a moderate wear. She's got several crowns that most of our patients do. You look at her CT scan. Oh, she's got some implants, root canals. Look, almost all the posterior teeth have been treated. So why? I mean, this patient doesn't look like she has a lot of cavities. I think most of this was structural. Most of her pain came from trauma, from occlusion, but it was misdiagnosed as tooth pain. So they root canal, they crown, and she looks good when you look at her mouth. So because her main concern was sleep, the Gelb Center treated her with the mat devices at night, and the Gelb, as you can see, it's right here in the back during the day as needed. So symptoms were resolved. All her symptoms were resolved. She was a happy person, but she could not bite back on her teeth again. Is that a good thing or a bad thing? I think it's a very good thing if you have that conversation with the patient at the very beginning, that your jaw is in a pathological position, it's retracted, it's living in your throat. We need to bring it forward to resolve your symptoms. Now, if your teeth don't mesh together, that doesn't mean that I moved your teeth. We move the jaw in a better position. And the solution is to either restore the teeth or move them orthodontically. Now, this patient, as you saw, she has several implants, so she's probably a better candidate. Instead of ortho extrusion, she's probably a better candidate for restorative. So to restore her function, that's what they did. You can see that they put her in a Myoaligner on top and bottom. symptoms are resolved. Just look at the her neck alignment. Look at her jaw alignment and neck alignment, how much it improved. Look at the asymmetry that she has in her shoulders. It's just really resolved. This looks like a different person. Michael, do you want to chime in a little bit? Or
if you go back one slide, so there's a lot of dentists. Go back one more if you can. So you made a great, go back one more even than that. You probably end up splitting the difference in this case. You might even do the job. You might even do it on the upper jaw and not the lower jaw, although they probably both, you probably would split the difference. So if you prepare the patient and tell them that they may have bite changes, but that's a good thing, they'll come back to you and goes, I'm doing great. I had the bite changes you told me about. And, they're fully expecting that, I can chew fine. The only one that's not happy in this case is the general dentist and the prosthodontist. They're really upset because they were told in dental school that the back teeth are always supposed to touch. Even if the patient's miserable, they're fine if the patient's miserable. They're fine if the patient's dying, as long as they can take shim stock and it holds on the back teeth. I used to give my friend Lenny Coburn a hard time. God forbid the patient feels great and their airways opened up, they're not clicking, the jaw's in a better position. From the get-go, this was going to be an ortho case or a restorative case. So exactly right. You prepare the patient. Once the patient's prepared, they're willing and able to do the restorative that's needed. That was a prosomnus on the top. And then they're either going to finish orthodontically or they're going to finish restoratively. It's a beautiful case. But you'd probably finish it on the upper and the lower arches. Come on, splitting the difference.
Exactly. And when you look at the starting case, you're like, this is a good occlusion. To most dentists, this is a good occlusion. So what's wrong with you?
It's a good occlusion until you evaluate the temporomandibular joints and the airway.
Yes.
And facial aesthetics and head posture and cranial cervical relationships.
Exactly.
Yeah, it's a great occlusion if you don't ask the patient any questions about how they're feeling, because that bite comes with a list of symptoms and pain.
Articulator not attached to a patient.
Yeah, it's like you separate. If we just took the teeth out of the mouth on a countertop, these connect okay, but they're attached to the rest of a human being. So it's a good bite if you exclude the rest of the human from it and you don't ask them any questions about how they're sleeping, breathing, and have any type of head and neck or back pain along with it. As soon as you go down the history list, now you know I've got a very bad bite here. So it's not about how the teeth might look touching. It's what does it mean for the rest of the patient? Because as the mouth goes, the rest of them goes. So you just got to go through all the connections and the questions. And that's why we have a medical and dental history. You take the medical history too, you start asking the questions, and then the connections are there. Then you know, yeah, this bite is not serving my patient well. This is an unhealthy mouth, which unhealthy body then.
Exactly. I never understood the concept behind the AM aligners. We have these deep bites, retracted mandible. You open the airway during the night with a MAT device, and then you force the jaw to go back into a pathological position. I think if the patient's symptoms resolve, then we know we're headed in the right direction. And we need to have that talk with the patient and just educate them, let them know that this is the right position and we need to rebuild the teeth to the correct position. This patient, unfortunately, spent a fortune on implants, broken crowns, but now she's in a plastic Myoaligner for over 8 months, and she hasn't chipped a corner or broken anything because she's in a physiologic rest position. She's not fighting her teeth to open up her airway. We used to think that grinding and clenching was related to, it was psychological, but more and more research is showing that it's actually an attempt to open the airway. And you can test that by just looking at the wear pattern. If you have a lot of wear on the canines, just have the patient just slide their jaw forward, duplicate that wear pattern, then have them just grind side to side on their front teeth and show them, say, see, this is how you're grinding. You're trying to open up your airway and make room for your tongue. Give them a mirror. The mirror can be your best friend and best educator when you're with a patient, because it shows them the pathology, what they're doing. And once you take that time, listen to your patients and educate them, the rest is very easy. These patients, as I said earlier, 30% of your patients are already in the practice, but they've never been educated. And you as dentists are in the best position to ask them about their science, ask the right questions, ask them if they sleep well, if they're grumpy in the morning, if they're a morning person, and then, a few answers will just lead you in the right direction. And you can, these are going to be long-term patients for you. They're going to be referring patients to you. You'll never have to advertise, because it's what you're offering is life-changing, not just fixing their teeth. So another exciting part that I wanted to cover is the applications in full mouth reconstruction. Not very many dentists do full mouth reconstruction. It's difficult. It's one of the most challenging things that you do in dentistry. So I had this patient. I'm in Portland. He came from Vegas. He's an executive there, and he had just gotten 2 veneers on top and like three veneers on the bottom because of the severe wear. But shortly after that, his veneers started to break. He had worn down teeth. A general dentist went in and put those. You can see that veneers are cracking on 8 and 9 and the opposing. So, when he came to me, I showed him that this is a pathological bite. You're just banging so hard on those teeth. You don't have enough tongue posture. You're constantly grinding your jaw more forward. So I asked him to kind of like give a test drive to this new bite position. I relaxed his jaw muscles, arrived at a physiologic position, and then put him in an upper and lower Myoaligner. I didn't do the 2 front teeth because they were already like really big. So I just covered the 2 segments on top and 3 segments on the bottom. You can see how tiny his teeth are, how little. And I always do a sleep study. He was mild to moderate sleep study. So when I brought him back after a few months, he came back and I did the sleep study. Sleep was resolved because he has all this tongue space now. So we're not claiming Myoaligner as a sleep device, but because we are changing the orthopedics of the head and neck and we're making room for the tongue, we're seeing that sleep improves. So you can see him with a mock-up of full mouth reconstruction. So these serve me both as my orthotic, as my night guard, as my diagnostic wax up. And imagine how much time I saved in lab. He just came here from Vegas, a few appointments. And then before I started my full mouth, I actually just used that bite registration, and I use it as a template. And basically, when I prepped his teeth, I was able to just park the Myoaligners in that bite registration, and as you saw, kind of like reline it and deliver it. So this is how we're making like full mouth reconstruction really easy. This is how I use the bite registration. You can see that's a Myoaligner that has been in his mouth. The only temporaries that I made during this appointment was the 2 upper ones, 8 and 9. So, and as I removed segments, I was able to start with a full bite registration. As I removed each segment and prepped it and scanned that, then I was able to just add to basically reline my bite registration. I measured tripoding, make sure that I did not lose the pitch-yaw roll of the mandible. I'm finishing the case. Basically did our, shake guides and things like that, prepped all the teeth. And now you can see Myoaligners were cleaned by my assistants. All the temporary cement that I had in it was cleaned off. And all I did was to just put that jig in his mouth. And what we're doing is doing some bonding, and then just relined it with our temporary material. And so I was able to deliver 28 teeth basically in 5 minutes because it was already done and adjusted. So it makes it really easy. And I have some exciting news that Lauren is going to announce, that we will, be having this course coming up soon.
Yeah, we're thrilled. So in February, I think we actually nailed the date, February 27th. We're thrilled to have Dr. Motlagh with her full restorative mini residency utilizing the Myoaligner. So stay tuned for more details on that.
So I prepped it in 1 day. I have a lot of experience with full mouth preps, and this makes it really easy. You don't have to prep it. If the patient cannot afford it, you can just do segments at a time. And the next case that I'm going to show, we actually had to spread the treatment because of financials for this patient. But in this one, I did it all in 1 day. And so I wanted to actually invite everyone to join our community. We ended up launching Bite Circle Community. It's a collaborative platform. It's only open to dentists that want to collaborate and talk about these cases. This is a HIPAA secure platform. It's free. A lot of us will just go ahead and submit cases and talk about it. We can submit CT scans on it and talk about cases and get guidance from each other. Collaboration is the key for improving our patient care. So make sure you join Bite Circle. It's a free membership. There's nothing tied to it. And it's just a really good, secure platform, much easier than WhatsApp to talk about a case or a Facebook page. There's different groups. You can belong to different groups: orthodontics, restorative, continuing education, research. And I highly recommend that you join and collaborate with us. So there's a lot of science behind this. I mean, Myoaligner is just a tool in the toolbox, but there's a lot of science behind anatomical orthotics, the science of relaxing the muscles to an ideal physiologic rest position. And make sure that I published a case, a very complex case. It's been a peer-reviewed study. Make sure you scan that, and there is 32 scientific studies attached to this publication to explain why we do what we do. So this is Michelle. This is the case that I published in that paper. She came to me. She's an influencer in Portland. If you ever come to Portland, you'll see her. She talks about different restaurants and the best places to go in Portland. She came to me and she was really concerned about her facial asymmetry, and she didn't want to do surgery. I mean, social media is her life, so she could not afford to be basically have jaw surgery done, and she had gotten several consults. That's a pretty tough case, for most dentists. You can see how she has that crossbite, unilateral crossbite, mandibles retracted, and her face looks completely asymmetrical. So to just make it easy, what I did was, going from a pathological bite, I relaxed her jaw and look at the midline between 8 and 9 and 24, 25. And again, that pitch jaw roll of the mandible, as soon as I just relaxed her muscles, and I use tensing in my practice to relax the muscles. I know there's different ways that you can do photobiomodulation and different techniques, but in just 1 hour, her mandible kind of like rotated in the right position. And I was able to capture that with a bite registration that we call MyoBite, and duplicate that with a Myoaligner. Look at her face before and after in about 3 months. And why 3 months? Because a lot of research has shown that we need that for bioremodeling. Dr. Singh has publications on this too, that functional appliances can actually be formational appliances. We're remodeling the condyles, we're remodeling the muscles. So her face became more symmetrical. Her chief concern was taken care of. Her TMJ felt better. You can see the joints are in a better position. And now she believes in what we do. And what we saw was a really small maxilla. Look at that pathological bite in May of 2019. So when she came back, after the 3 months, we talked about maxillary expansion, and we did that. There is, post-expansion. Actually, that post-expansion is 6 months later. Look at that canine. Look at the canine, how it was kind of like in an angle. And she actually went to a surgeon, got a surgical consult. But as my partner, Dr. Terry Lynn Tennant, started expanding her, that canine started to drop into the oral cavity, and the baby teeth that were retained started to fall off, which was a great thing. The pandemic happened, so the treatment was delayed a little bit, but so we had our mandible now in the right position. We tested it. Maxilla was expanded, and we went ahead and did some ortho on her. You can see that canine right in here, right in there. That canine's being born. We gave her the option to do some surgery and bring that canine forward. She decided not to do it. So we went ahead and we went with the expansion. After the expansion, she lost some of the baby teeth, as you see, the retained baby teeth. So we had to do some restorative. So look at this case. Phase 1, orthotic therapy, get her out of pain, address her chief concern. Phase 2, take care of that crossbite, expand her maxilla because her mandible was bigger than her maxilla to start with. Expand that maxilla. And when you have a myoliner, so I think we kept the myoliner on the bottom, and then we did a DNA device on top to expand her maxilla. And because she had the myoliner on the bottom, when jumping that crossbite, we didn't run into natural teeth during the day because DNA is only worn like 12 hours at night. So as we were expanding, we were able to just shave the buccal cusps of the myoaligner and let her jump that crossbite. So she jumped the crossbite. She looks good. This is with a myoaligner now on the back teeth because now she lost some baby teeth. She's showing spaces. So then we went to an upper 2-segment myoaligner, removed the bottom one. And you can see that posterior open bite, the gap. And this really phased out the treatment, as you see from 2019 to 22, kind of like expansion happened. And then I think it took another 2 years for her to, come up with the money and kind of like do the restorative and the next phase. So it made treatment really possible for her. Look at her CT scan. Look at the asymmetry that she had in her airway. The airway looks a lot better. Expansion happened. Pneumopedics, the science of remodeling the upper airway, which only us dentists can do. And look at her face. Face is much wider, breathing is much better, neck posture is much better. And then we finish with some veneers in the front. So this case was a lot of steps done, but it really made treatment possible and affordable for patients. And you can see this case in that article that I shared. If you go to myoaligner.com, if you couldn't scan it, if you go to myoaligner.com, on the right-hand corner, you see research and you can click on that. And then all the citations that I use in that publications are there too. Is there any questions or comments here?
Yeah, before I show up the questions, Dr. Gelb, you wanted to say something?
No, I wanted to say there's a lot of good questions. I want to make sure we get to it before as many as you can in the Q&A, but yeah, please keep going.
So do you want to take some questions, Dr. Motlagh, now, or you want to do one more case?
We can take some questions.
Sure. Okay. How long does it take to make myoaligners?
We asked for 3 weeks because we're a nationwide lab. So when you submit your case, you'll have it in your office between 2 and 3 weeks.
And then home care, if they can't floss, would be water pick?
They water pick, yes. Or they can just pop it off, brush their teeth, put it back on.
Does the myoaligner affect the implants, or is there any movement of the implants?
No movement on the implants. We did a 5-year study. We looked at it. It doesn't move things. It's just like an onlay that sits right on top of it. Actually, in a lot of cases, the dentist will put the implant abutments on, and then they test drive the occlusion with myoaligner before they go to their final implant restorations.
Do you tend to cement most of these or leave them as removable?
It depends on my case. If I know that I'm going to go to phase 2, I like to have it cemented because then it's just more convenient for the patient. And the ones that are cemented, we build them to height of contour so the designers know to design them and leave the embrasures open for water picking. I recently had a patient that moved from Newport Beach, that came here from Newport Beach, unfortunately. So I put him in a cemented myoaligner. Unfortunately, he was hit with really bad pneumonia, ended up at ICU and all of that. So he was actually, even though I cemented it with Tampon Clear, he was actually able to just lift it and take it off before his surgeries. So it's very safe.
Thank you. What is the product made out of? Curious what the current charge is for this product as well.
We make the product out of polymethyl methacrylate right now, but there is several more material is going through FDA that will make it even stronger. Right now, PMMA is kind of similar to acetyl resin that you've seen with Snap-on Smile, but with acetyl resin, you cannot bond composite to. We do it with PMMA because it's segmented, and you can bond composite to it from, as you saw, you can reline it and use it as your temporaries. So PMMA is it. And they almost cost per tooth. Yeah, per tooth, they're almost like a diagnostic wax up. So as far as the charge.
Does the Myoaligner also expand the mandible and maxilla as well, or is it just a placeholder?
It's a placeholder. It maintains the mandible, your mandible in the right position. It does not move teeth.
Is the reason for not crossing the midline as one unit the same for not using a bonded upper anterior retainer?
Repeat the question, please. I don't understand.
Is the reason for not crossing the midline as one unit the same for not using a bonded upper anterior retainer?
Probably it could be the flexion of the maxilla and mandible and the sutures that is causing that. Yes, making the anterior retainers fail.
And how do you take your myo bite? Are you guiding them to your preferred position or current bite? And how are you determining the position?
I do my myo bites by relaxing the muscles and arriving at the physiologic rest, and a couple millimeters on that on vertical trajectory is my myo bite, basically. But as Dr. Gelb mentioned, there's different techniques out there, and we can teach you in our classes. My technique, the myo bite technique, is taught at the Myoaligner Academy. And I'm sure Dr. Gelb can cover his technique with the phonetic bite.
And then last question for now, we'll carry on, is what if the patient is not ready to move forward with full mouth reconstruction or ortho? How long can they be in myoaligners or other options for them?
I've had patients in it since 2017, and surprisingly, they're not wearing as much as I expected, maybe because they're not in a pathological position, so they're not grinding and clenching as much. And we save all the files, MyoHealth technology does, so we can refabricate one for you. Some dentists have ordered like 2 for those that have patients out of the country. So that's always possible too.
Okay, great. I think we caught up on.
Another fun case, Dr.
Nagata.
Miraglia
or Dr. Gelb wanted to add before we move forward?
Oh, good.
Okay. Okay.
So how would you treat this if this patient showed up in your office after oral surgery and she wants front teeth? What would you do? It's send him to bed. And if you do clear aligners, you have to fill 6 teeth at every step. It's going to be a nightmare. You can't do ortho. It's really tough. And if you put a flipper or denture in there, you're going to have a posterior open bite. So, as I said, our motto is making a simple solution to a complex problem. So Dr. Nagata is a very experienced dentist. He decided to go ahead and just handle the bite. And he arrived at that position for her ideal bite, and with 2 segments Myoaligner on the posteriors. You can see her face, mandible moved forward, patient's out of pain, she's happy. Now this is a simple case. He went ahead and placed the restorations. You can see he had cemented the Myoaligner. There's still some excess cement there that he did. And now this is a very easy case for even ortho, because there's a lot of lingual inclination of those teeth. There's some crowding, and you can easily upright the posterior teeth by removing the Myoaligner. So this case almost took easily a year before he went to the next phase, but the patient was chewing and functioning in a nice, comfortable bite. Another great case, one of my favorite cases done by Dr. Merchant, this patient, elderly patient, she came in, her chief concern was obviously her teeth, decay, and sleep apnea. So what Dr. Merchant decided to do was to just basically do a full mouth reconstruction with Myoaligner in phase 1, and she decided to go ahead and cement them on. The patient comes to her practice every 6 weeks for maintenance. She's water picking. Even her assistants, in a few minutes, they can just lift the Myoaligner, make sure she's cleaning well underneath them, and then cement it back on with a temporary cement. And I know she's gradually restoring the teeth, because after a year, she asked for the lower right segment to be remade. And for that, because she probably did enough crowns, that she didn't want to spend time retrofitting it. So she kept 5 segments in, and she just scanned that section and asked us to make her a new segment. So you can get very creative with this. It can be a tool in your practice that can come in very handy. Other applications, we're seeing that in cosmetics. If you have patients that are constantly getting fillers in their lower jaw or trying to get Botox to have a more prominent jaw, this is on our promotional material on our patient brochures. So cosmetics, we've seen that. This is one of my patients that came in. She was really concerned about the lower face, the deep marionette lines. I went ahead and did the Myoaligner. She loved it. And then she asked me for a more permanent solution. So I ended up doing a full lower arch reconstruction. So this can be kind of like a gateway to more dentistry in your practice as well, but with confidence that you're testing something before you go to the next phase. So it gives your patients a lot of peace of mind. We've had some of our providers, Dr. Hermie uses for Charles Bassi. If you follow NBA, he's the first person that's bigger than our banner. So he was very happy. He said that it really improved his function. There's a lot of research in the research article that I shared. There's references to how an optimal jaw position can improve athletic performance. And I know a lot of athletes, we have at least 4 professional athletes in Myoaligner now. It's discreet. So, if you're a golfer, you don't want to have a big bulky mouth guard in your mouth, they can just wear that and improve their performance. It improves range of motion. And I always do like a posture, like a strength test on my patients before and after to show them how it can impact that. So there's a lot of practice benefits. I used it out of frustration with other techniques that was available. And now I'm so glad that a lot of our providers are using it in ways that I didn't even think about. One example, at the end of the day, we are all here to improve our patient cares, to get those 5-star reviews from our patients. Dr. Lamothe is actually contracted with the VA. So in his first year with us, he did 25 cases of Myoaligner, and he billed them to the VA, and they paid for it. One case in particular, it was a heavy grinder. Patient was on a lot of pain medication and anxiety, sleep issues. So he really lifted the bite with upper and lower Myoaligners, basically did a mock-up of a full mouth reconstruction. And this patient came off all his medication, and it was such a proof of concept for the MD at the VA that they actually wrote a prescription for full mouth reconstruction, and they paid $60,000. So that was a big milestone for us, because now medical is paying for dental, because now medical doctors are understanding the connection between tooth size and dimension, with anxiety, with sleep, with pain. So, and I have a patient right now that is going through full mouth reconstruction. He's with the VA too. So far we've gotten $35,000 approval from the VA to pay for his full mouth reconstruction. And that's how we're bridging the gap to medical. And we'll show you how to bill medical for it with the right codes and our FDA approval. So we're really glad that we're bridging that gap. Another great story that I want to share is Dr. Handa. She's an Airway patient. She did not treat any TMJ patients. The first year with us, she did 12 months, she did 38 cases, and she decided to charge $5,000, which is average. I know the Gelb Center charges more, but you guys are in the best part of New York. So she charged $5,000 per case. So, I mean, at the end of the day, we want to make sure that we have healthy practices and happy team members too. So not only she boosted her production by almost 20% with just one device, but it opened the door to a lot of phase 2. And actually for a while we didn't hear from her. So when I called her and I said, how are you doing? She said, I'm looking for an associate. I have so many cases. Most of these cases are going into ortho or restorative. I cannot keep up, which is a great problem to have as a dentist. It can be a gateway. And she was actually a speaker at our last webinar. She has a great way of listening to the patient and patient presentation. So at the end of the day, we want to make sure that we increase your patient satisfaction, compliance, and your production, and decrease your chair time, especially with the full mouth course. You will see how much time you save and how much lab cost you save when you do your case, when you combine your orthotic, your wax up, and your prefabricated temporaries, and with all one device with Myoaligner. And it really reduces the liability. You know, I used to do a lot of fixed orthotics, like bonded composite and things like that. And when they're bonded to the teeth like that, it's permanent restoration. But Myoaligner is on with a temporary cement, so FDA looks at it as a temporary basically crown or onlay. So the liability is much less, and you don't have so much strain. So, you know, we are now a full-blown company. MyoHealth Technologies started with a vision, but we're growing. So we have an educational arm, and we're constantly doing R&D into more devices. So stay connected with us. We're trying to enable general dentists with specialty services so they can expand their services. They can keep patients in their practice and increase their patient care levels. And for that, we have a turnkey online learning platform. We launched pretty much after the pandemic, so we decided to have most of our courses online, our onboarding, and we give you ongoing technology support and the devices that are approved by the FDA. So our onboarding, and Lauren's gonna follow up with an email, and our onboarding is pretty robust, and it covers education. It covers a workshop that you can do a hands-on for a whole day implementation for the team, and clinical consults. I think they're very important. I've seen thousands of these different cases go through, so I like to hop on a call with our new dentist and make sure that I hold hands for the first few cases before they go, and it's all virtual, so it's very easy. And we like to include some tangibles like a sample device, brochures, and your first device, that I highly recommend doing it on your own or a team member. And very importantly, the FDA-cleared care instructions, customized medical super bill or consent forms, chart notes, everything. I have made everything into a nutshell for our providers, and a support portal that you can constantly stay in touch with us and make sure that you're not out there alone. So Lauren, did you want to say something about the email? And
yeah, absolutely. So I know everyone's thrilled and wants to learn more about this. So we will follow up with a link to onboard if you wanted to with the Myoaligner accelerated onboarding. We do offer 20% off, so that link will be given to you as well with the coupon. We're putting it in the chat in case you want to learn a little bit more about it. But we will follow up in the email, so you can then actually maybe Dr. Motlagh forward to the next slide with Tama, so they can contact Tama and learn more about it, and get in touch with you ultimately if there is direct questions. So we're just so thrilled that this is a solution, we feel. I mean, our platform is called Airway Solutions, and it's just the future, and we're really excited, and congratulations to you and your innovation on being the solution that you want to see. So really kudos to you. So impressed by your technology and your dedication and caring. So thank you for really bringing this to the forefront.
Thank you. Grateful to be part of this team and collaborate with you all. Have a lot of respect for what you have done with the Airway Health Solution, and really looking forward to this. Yes, I would be happy to hop on a call if you have more information. Reach out to Tamo. Actually, if you just scan that code, it directs you to Tamo's calendar, so she can learn more about your practice and arrange a call with me. I'm happy to learn more about your practice through a virtual call. If you have a case that you want to discuss to see if it's a good candidate for Myoaligner, I would be happy to do that. And as I said, we're just finding new ways to do this. This is not just a tool, it's becoming a toolbox for us. So, I can share my experience from what I have seen from different providers. I would be more than happy to do a virtual call before you commit to onboarding, and just show you the assets, some of the assets that we can give you through the onboarding.
And then you want to stop or keep that code on. There are some more questions here that I would love to help to answer. Is how many Pontics can you have in a segment to still have good retention for the Myoaligner that is not cemented?
We usually do 3 segments for arch, and we try to have 1 cantilever if it's, if you're missing molars. So off of a bicuspid, for example, if you just have the two bicuspids or a canine, we cover the canine and then we give you a cantilever. But if it's a bridge, the PMMA material, it's a really reinforced mill PMMA, so it's very, very strong. It can cover two missing teeth, two missing molars and premolars.
And do you need a certain height of contour on the teeth, or can Myoaligner this still work on short teeth?
It can work on short teeth. If you have super, super short teeth, you just cement it on, and then we make the embrasures go in. So we're using internal retention in the embrasures, and you can always just bond and add a touch of composite to that embrasure and make it, even in the mouth, make it a little bit tighter. You would be surprised how much retention you see with these.
Okay. And Dr. Gelb, Dr. Miraglia, let's just have some comments on the cases that we've seen and how the general dentist and a specialist can utilize this technology.
I mean, I'll go first this time, maybe. There's so many ways to use it. You can use it as your primary treatment, and it works for airway because you're increasing vertical and you're bringing the jaw forward. So when you bring the jaw forward and you open the vertical, even though you might still have a narrow maxilla, you can still sometimes get away with improvement. It might not be total improvement. Sometimes it is. It depends on the patient. So sometimes you do an orthotic, like I'll do a Gelb appliance, in the lower, and then I'll go to the Myoaligner after that. Then I'll go to either ortho and restorative after that. So I like to go slow sometimes. I like to prove the concept. I always love to prove the concept because I find that the patient likes it. The older the patient, the slower they want to go. The younger the patient, you go right into ortho, typically. So the older the patient, these are the people that are, they've all lost vertical, but I think it really is age appropriate. So I think it's a wonderful technology. I think you can implement it with what Ben has taught you, what I've taught you. It really goes well with our philosophies in that it's either interim solution. I didn't like some of the stuff. Listen, in New York City, I'm not I just wrote a note for my office manager to get everyone back in. You don't want to lose these patients to follow up and then have them come in with 12 rotted teeth, and then you get sued, or they have to have 12 teeth or 14 teeth extracted because they ran away with this thing and they got decay underneath it. So listen, that's my fear. That's my warning. I haven't seen it because hopefully, but I'm going to go back, and I have a lot of them out there. I'm going to make sure that someone's not thinking that this is the permanent treatment. So even though Dr. Motlagh says she's had it in since, I get the shivers when she says she's had it in since 2017. I don't think that's a good thing. So I'm going to encourage.
It's been removable. It's been removable. The patient pops it in and out.
If it's removable and the patient cleans it, that's great.
Oh, yes. Yeah, they're removable.
But I want to encourage my patients to move ahead with treatment. The worst case is someone who can't afford it. But listen, it's an interim solution. I think that's best. We can best leave it at that.
Yeah, this whole system is very impressive. And so from the moment I saw it, I knew this was going to be amazing. So happy we're at this stage and looking forward to next. It's a wonderful tool for our doctors to have. It's definitely the next step in the evolution of treating your airway, sleep, breathing, TMD, basically underdeveloped collapsed mouth. This is certainly a wonderful opportunity. So to have our AHS family be able to take this kind of education into their practices, offer a whole next level of service to the patients. I'm excited to basically keep seeing the patient outcomes going forward. You could see today from what Dr. Motlagh accomplished, and then not only that, having done the research to become FDA approved. That's a big deal to be able to have the approval for. Yeah, that is a big deal. She knows what it takes to do that. Michael knows what it takes to do that. I know what it takes to get that. And I've never achieved that. And so that is utmost respect for someone who would go through that process. Because
we were rejected 3 times until we sent the right documents and the research. And yes.
I'm aware. Yeah, we've talked about this. You've told me the process that you went through to get that and to achieve that. And never mind the results in the mouth and how the conversion of the patients, but On the aside level is you're doing all of this processing through the FDA for approval, which that's a full-time job in and of itself. But to have the results to get that is, yeah, very big deal, very big accomplishment. So really looking forward to our doctors having access to this. It's a wonderful step forward in being able to treat patients, and with more confidence and more security, knowing you're going to have a wonderful outcome for your patients.
And I like to add that our goal is to get the patient to that final optimal position. And yes, Myoaligner is a transitional, and we're just helping them through this transition, lowering our own liability, basically transitioning the patient. But what you're going to learn from us is how to do finalize with restorative, whether it's a partial reconstruction or full mouth reconstruction. With Ben, you're going to learn how to now transfer these cases into clear aligner and not have to do 10 refinements, to get there. And even, in the hands of most experienced dentists, I've seen that, sometimes they start a clear aligner, they're hoping that the mandible will end up in the right position, but then the jaw gets stuck, and who gets blamed? It's the dentist, because you didn't bring it up in the beginning that their jaw is in a pathological position. So it's a safe way to transition your patients into final. They need to understand it's an orthotic, but it's just a functional orthotic that they can wear and function with. And yes, you do not want to bond it unless you know that the patient is going to phase 2. And another thing that we cover both in our consent forms and in the FDA instructions, it does outline the risks for cavities, for periodontal disease if they don't follow up. So all of those are discussed both in our consent forms and in the care instructions that patients get. So having that conversation with patients is important. And that's why in our onboarding, we cover step by step. We have like 6 appointments in the 3 months for Myoaligner, from the initial consultation to the final consultation, which is phase 2. Even if I cement it on and the patient says financials change and they cannot go to phase 2, then we'll just take it off, clean up the temporary cement, and then have them just use polygrip powder, which acts like a temporary cement for us. So it's really important to have that relationship with the patient and have good communication with them.
Thank you, Dr. Motlagh. As I mentioned at the beginning, here you have the dream team here, and you can actually learn from all of them and then apply those techniques into your practice. I did want to announce our birthday sale. Can you believe it's 7 years, Dr. Miraglia, wow, since we kicked this off? And we're just so thrilled that, we're continuing to develop the solutions and provide everyone with techniques. And so we do want to offer these discounts that will expire August 31st. I don't want to spend too much time on this because I did want to address our questions. So all of our courses are on our website. I really encourage you all to look at these, because these experts here are teaching you how to do this in your practice. And we hope you take advantage of that so you too can help your patients from start to finish. So these are some of the courses that we do provide with our top lecturers. And again, I would love to have a call if you have any questions, want to set up a journey, your own pathway. I'm here as a support for you as well. We do have our next conversation coming up September 17th, all about Airway Palooza. So I hope you all can come. It'll be a fun night. It'll be a lively night because we have a lot of people joining us from all over. So please save your calendar, September 17th. To join us for that. We do have an interesting live event coming up that Dr. Miraglia is running October 10th and 11th. It's the Minnesota AGD, Expansive Airway Orthodontics for Children and Adults, the 2-day hands-on. So that's something that you may want to consider traveling for. Here is the information, and it will also be on our follow-up email. And then I hope I see everyone in sunny Florida. All of us will be here on the panel tonight. And you'll learn a lot from these experts, and you'll also gain insights from your fellow colleagues and community, whatever your journey is, wherever you are on your journey, whether you're new or you're seasoned, everyone comes away learning something and bringing something back to share. One special announcement, I didn't want to be remiss, but I am so thrilled to announce that my daughter, Devin Kilmeade, is now president of Airway Health Solutions, and we were featured in the Do Magazine blog. So I thought that this actually deserved an article rather than a press release, because it's quite a journey, and I'm really thrilled as a mother and a CEO to announce this tonight. So welcome, Devin, and I know that together we will just be moving forward. So welcome, Devin, to the AHS team. I think it is time for the raffle, and then we'll just have a quick closing thought. So I'm going to have Gerald share his screen, and we're going to give away a Fundamentals in Airway course with our raffle in just a moment. So until that comes on, let's just have a final word, Doctor. Oh, here, we're going to do the raffle. It's ready. Hold on. Give it 1 minute. Okay, so you have to be in it to win it. So let's see who our lucky winner is tonight. I don't know if my internet's slow. Did someone come up? Sheldon Shu. Okay. Congratulations. You are our Foundations of Pediatric Airway Healthcare course winner, and we will contact you with the details. So thank you, Gerald. Let's stop that share, and let's just have a quick closing thoughts. I want to share my closing thoughts. Dr. Motlagh, thank you so much. We are thrilled to have you on board as faculty, and you're part of the solution. And thank you for your innovation and dedication. Do you have any closing thoughts you'd like to give, or any of the panelists, before we say goodnight?
No, grateful to be here tonight. Thank you for the opportunity, and we'll just continue with the innovation and research, and for the best interest of our patients. It's a collaboration between among all of us that is the key, and I'm really excited about this opportunity.
Yeah, just real quick, I thought it was a great talk. I learned a lot, and I'm really happy to be collaborating with all of you. And welcome to the team.
Thank you.
Okay.
Yeah, that was just inspirational. Thank you, Dr. Motlagh, and I'm looking forward to the collaboration going forward. Thanks again for all of the things you do to help patients become healthier and giving us better tools to do it. Appreciate you.
Thank you.
And take advantage of the 20% off the enrollment. That's through AHS. That will be in your follow-up email, or you can click on the link on the side. Dr. Motlagh, thank you. Welcome again. Thanks everyone for your commitment and for being here. We can't do it without you. So as long as you show up, we'll show up too. Have a great night. See you in September.
Thanks, Lauren.
Good night, everybody. Thank you.
Good night.
Good night.